Hello students. Welcome to part 2 of chapter 66. We're going to talk about pelvic organ prolapse. So first, let's start with a video to understand better this concept. Pelvic organ prolapse.
Pelvic organ prolapse is a group of conditions in which one or more pelvic organs drop from their original position into or out of the vagina. Normally, the pelvic organs are held in place by the pelvic floor muscles. Prolapse happens when these muscles are weakened and can no longer offer proper support. A prolapse can be of different degrees, ranging from mild to severe. More than one organ may be affected at the same time. Most commonly, the pelvic floor muscles weaken as a result of pregnancy and childbirth, especially vaginal birth. But the impairment can also be caused by aging, obesity, previous pelvic surgeries, and conditions that increase abdominal pressure on a regular basis, such as chronic coughing or constipation. Common types of prolapse include prolapse of the urinary bladder, called cystocele, prolapse of the uterus, or uterine prolapse, prolapse of the rectum, called rectocele, and dropping of the top portion of the vagina toward vaginal opening, called vaginal vault prolapse. This type commonly happens after surgical removal of the uterus, which normally holds the vaginal vault in place. A prolapse can be very uncomfortable and may cause pain or pressure in the pelvis or lower back. Depending on the organ that is affected, symptoms may also include urinary problems, constipation, or painful sex. Treatments usually start with pelvic floor exercise, such as Kegel exercise, to strengthen the muscles. Biofeedback techniques may be used to help patients identify and squeeze the right muscles. In postmenopausal women, low estrogen levels may be responsible for the weakening of pelvic floor muscles. In this case, a vaginal estrogen supplement can be effective as treatment. A silicone device called a pessary can be deployed vaginally to hold the prolapsed organs in place. Pessaries are available in a variety of sizes and shapes. They are removable and should be cleaned regularly. Surgeries may be performed to repair the tissue bulge, but recurrent prolapse is common after a surgery because it doesn't repair the underlying weakened muscles. There are several types of surgeries for different types of prolapse. The most commonly performed are removal of the uterus to correct uterine prolapse and attachment of the vaginal vault to certain structures in the pelvis to repair vaginal vault prolapse.
Thank you so much. So now let's get deep into this lecture. So, uterine prolapse, the most common type of pelvic organ prolapse, can be caused by neuromuscular damage of childbirth, increased intra-abdominal pressure related to pregnancy, obesity, or physical exertion, or weakening of pelvic support caused by decreased estrogen. The stages of uterine prolapse are described by the degree of descent of the uterus through the pelvic floor. Whenever the uterus is displaced, other structures such as the bladder, rectum, and small intestine can protrude through the vaginal walls. A cystocele is a protrusion of the bladder through the vaginal wall, urinary bladder prolapse, which can lead to stress urinary incontinence and urinary tract infections. A rectocele is a protrusion of the rectum through a weakened vagina wall, which is called rectal prolapse. So, patients with suspected uterine prolapse may report a feeling of something falling out. You need to be aware of the verbal, the words that the patient is expressing so you can identify exactly what to expect and how your assessment could be done. So when the patient is telling you, I feel something is falling out, dyspareunia, we know already what that means, backache, or heaviness or pressure in the pelvis. A pelvic examination performed by the healthcare provider may reveal a protrusion of the cervix or anterior vagina wall when the woman is asked to bear down. And here comes, that's good to know. Ask the patient whether she has urinary elimination problems, such as difficulty emptying the bladder, urinary frequency and urgency, a urinary tract infection, or a stress urinary incontinence, loss of urine during activities that increase intra-abdominal pressure, such as laughing, coughing, sneezing, or lifting heavy objects. These symptoms may be associated with a cystocele, which is the bladder prolapse. So one thing is that a woman is going to feel that she's having urinary incontinence because of a long period of laughing or coughing, right? A long period. And another thing is that by by having a coughing event, just a few minutes or seconds, she's gonna have urinary incontinence. That's something different. Or maybe it could happen when somebody is vomiting and just this event causes urinary incontinence. Okay, think about it. Diagnostic assessment methods, they use the speculum and bimanual examination, retrovaginal examination, pelvic floor muscle testing, pelvic organ prolapse quantification is a system assessment to identify the staging in order to decide for surgical procedure. So here you have in the image the different types of prolapse. What is the intervention? Non-surgical management teach women to improve pelvic support and tone by doing the floor muscle exercise or Kegel exercise. Spay filling devices such as vaginal pessary can be worn to elevate the uterine prolapse. Women with bladder symptoms may benefit from bladder training and attention to complete emptying. Management of a rectal cell focuses on promoting bowel elimination. So for that, the patient is going to be recommended to have a high fiber diet, stool softeners, and laxatives. Okay, surgical management. Most women with symptomatic prolapse are treated with a reconstructive procedure, which may or may not include hysterectomy. Synthetic mesh is often used in transabdominal prolapse repair. Mesh intended for transvaginal surgical repair was discontinued in the United States in 2019 because of complications associated with this procedure. So I want you to differentiate when the mesh repair is doing transvaginal, okay, and from other type of repairs. And we are going to watch a video that is going to give you the updates of on the mesh repair when it's done transvaginally.
To Deborah Mendelsohn, exercise is a key part.
What happened? We are having a connection issue.
Of health and happiness.
And I've even been doing a little jogging and walking, so that's what I love.
Like many women who have children, Deb developed stress, urinary incontinence, and pelvic organ prolapse.
So if I coughed or sneezed, I'd have to, wherever I was, I'd have to go home and change, and it was really inconvenient.
Very common. So she opted to have doctors in her hometown implant pelvic mesh for both her incontinence and prolapse. It worked for several years.
And then I developed another prolapse, so I went back to my surgeon, who did further mesh surgery.
For a while, that worked too. Then the pain began.
A scale of 1 to 10 of the pain, my pain was probably at about 11 prior to the surgery. I was extremely distressed, and to be honest, I didn't feel my life was worth living. I had no quality of life at all.
Deborah's search for help led her to Mayo Clinic and urogynecologist Dr. John Gebhardt. He says the most common problems with mesh implants are erosions or extrusions, meaning the mesh starts to poke through tissue and skin.
Could lead to bleeding, irritation, discharge, maybe complaints with intercourse.
Here's what happens. Pelvic mesh is implanted to bolster organs, to give them support. Over time, the body grows in and around the mesh, and this holds the mesh in place. In some cases, the mesh contracts and begins to move, causing potentially serious symptoms. Surgery to take out embedded mesh can be very complicated and difficult.
We removed a significant majority of the mesh that was placed for her. We didn't remove it all because some areas weren't an issue.
Deborah has had 2 surgeries to remove the mesh. Some is still there, but she feels worlds better.
Absolutely fantastic.
Now she's back on track.
I have got back into physical activity, which is great.
Back into life. For the Mayo Clinic News Network, I'm Vivian Williams.
Thank you so much. So that's what happened when the mesh is placed transvaginally. And the worst scenario is when they try to remove the mesh, that some of this product cannot be removed because it's already too much inserted into the tissue. Okay, so that's why they discontinue the transvaginal procedure, right? Okay, nursing safety priority. To be certain that the patient is fully educated about a surgical procedure using mesh, provide information for her to review before the surgeon discusses and obtains informed consent. Yes, we nurses, we are advisors, right? We really need to inform the patient before the procedure is suggested. The surgeon will ultimately obtain consent after reviewing details about benefits and risk of the procedure, specifically about complications that may arise when using synthetic mesh. Reinforce information about possible adverse events, the signs and symptoms of infection, and when she should contact the surgeon. Provide the patient with the manufacturer's label and written information. Teach patients who have just had the mesh procedure to avoid strenuous exercise, heavy lifting, and sexual intercourse for 6 weeks. If you notice, most of these procedures and disorders related to the GYN, the time to rest, even for breast, the time to rest and have a special considerations and nursing care is 6 weeks, okay, in average. Increasing intra-abdominal pressure, some of the activities that they need to avoid, like constipation, weightlifting, cigarette smoking for a minimum of 3 months to allow proper healing and prevent prolapse recurring. Another procedure is called the anterior colporraphy. Is an anterior repair that tightens the pelvic muscles for better bladder support, and is usually performed only after the patient has unsuccessfully tried conservative management and continue to have bothersome symptoms. This procedure is usually deferred until the woman no longer wishes to have children. Teach the patients to adhere to preoperative teaching and to consult her surgeon about the possible use of transvaginal estrogen prior to the procedure, which helps to maximize vaginal mucosal thickening. Let's watch this procedure, anterior colporraphy.
With patient in dorsal lithotomy, place Foley catheter for recognition of the urethrovesical junction. Use 2 Alice clamps to grasp the vaginal epithelium at the urethrovesical junction and at the vaginal apex. Inject hydrodissection solution subepithelially. I use 20 units of Pitressin, 20 cc's plain 0.5% Marcaine in 100 cc's of normal saline mixture. I typically use 20 cc's of mixture for the hydrodissection. With a scalpel, incise the vaginal epithelium between the 2 Alice clamps, from the urethrovesical junction to the apex.
The apex.
Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Surgical tips. Place an Alice clamp on the epithelial edge. Using your forefinger as traction, use Metzenbaum scissors to carefully dissect the fibromuscular layer away. An assistant can maintain traction medially on the underlying muscularis tissue layer with atraumatic pickups. Providing traction and countertraction is very important for a clean dissection. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. With 2O delayed absorbable suture, plicate the prolapsed fibromuscular layer in 1 or 2 mattress layers. Surgical tips. Avoid tension and avoid taking excessively deep bites to prevent injury to the underlying trigone and ureteric orifices. If the prolapse is particularly large, consider placing an initial purse string suture. Trim excess vaginal epithelium and re-approximate the vaginal epithelium with 2O or 3O delayed absorbable suture in interrupted, subcuticular, or running fashion. Perform cystoscopy for evaluation of bladder integrity and ureteral patency.
How these surgeons are equipped with all these instruments, right? And simulations and maniquees to learn how to perform these operations. This is amazing. So we saw the anterior colporrhaphy, and the nursing care for a woman undergoing this procedure is similar to that for a woman undergoing a vaginal hysterectomy. Okay. So, although there are a number of approaches to managing posterior vaginal defects, traditionally the posterior colporrhaphy, which reduces the rectal bulging, is used most commonly the posterior colporrhaphy for rectal prolapse. If both cystocells and rectocells are present, an anterior and posterior colporrhaphy repair is performed. So we saw the anterior, now we're going to see the posterior colporrhaphy. Okay, here we go.
With patient in dorsal lithotomy position, an exam under anesthesia is performed showing the posterior compartment defect. In the posterior fourchette, the edges of the posterior defect are grasped with Alice clamps. The vaginal mucosa is hydrodissected up to the cervicovaginal junction with dilute solution. We use a mixture of 20 units of vasopressin, 20 cc's plain 0.5% Marcaine, and 100 cc's of normal saline. An incision is made in the vaginal mucosa and carried caudal down from the posterior cervicovaginal junction to vaginal introitus. With meticulous, sharp dissection with Metzenbaum scissors, the vaginal wall is dissected free from the underlying rectovaginal fascia using Alice clamps for exposure and countertraction. The dissection is carried to the right and left sides of the midline to the lateral levator ani plate. If an apical defect is encountered intraoperatively, the defect can be further dissected and suspension procedure of choice can then be done for apical support.
Okay.
The rectovaginal fascia is then reapproximated in the midline with a running suture of 2O vicryl to the upper perineal body. If redundancy is noted, a second imbricating layer is then done with 2O vicryl suture. Palpation is done to ensure good, solid anchoring and support without any ridges of tissue, as this is a common source of dyspareunia. The redundant vaginal mucosa is then excised. The vaginal mucosa is reapproximated in the midline with a running suture of 2O vicryl up to the upper perineal body. Rectal exam confirms excellent support to the rectovaginal septum and no sutures in the rectum.
Perfect. Very interesting video. Thank you so much. The nursing care after a posterior repair is similar to that after any rectal surgery. After surgery, a low residue, low fiber diet is usually prescribed to decrease bowel movement and allow time for the incision to heal. Instruct the patient to avoid straining when she does have a bowel movement or she does not put pressure on the suture line. So she does not put pressure on the suture line. Bowel movements are often painful and she may need pain medication before having a stool. Provide seat baths or delegate this activity to assistive personnel to relieve the woman pain. Interesting. So, as I always say, pay attention to your NCLEX examination challenge questions. Okay. Let's go with the endometrial cancer. Let me see how much information is on this. Probably we can do this. Okay, so endometrial cancer Where is it? I passed it, right? Okay. Um, is the cancer of the uterine lining is the most common gynecologic malignancy. Its incidence continued to rise in the United States with an estimated 65,000 more than 65,000 new cases diagnosed annually. Endometrial cancer grows slowly in most cases, and early symptoms of vaginal bleeding generally to prompt evaluation and treatment. As a result, this type of cancer has a generally favorable prognosis if it's diagnosed in the early stages. Adenocarcinoma of the endometrium is the most common type of uterine cancer. Abnormal uterine bleeding is the most common symptom resulting from estrogen exposure that leads to endometrial hyperplasia. So let's see the figure. This is the stages of the endometrial cancer that you need to know to be familiarized.
The uterus is formed of corpus and the cervix. Stage 1 is confined to the corpus. When the tumor involves the endometrium, or up to 50% of the myometrium, it's called 1A.
1A.
When the tumor involves 50% of the myometrium or more, it becomes 1B. When the tumor invades the cervical stroma, it becomes stage 2. In stage 3, the tumor extends locally outside the corpus and cervix. In 3A, it invades the serosa and or adnexum. In 3B, it invades the vagina and or parametrium. 3C includes lymph node metastasis, pelvic lymph nodes, 3C1, para-aortic lymph nodes, 3C2. Stage 4 involves distant metastasis.
Claro.
4A includes the invasion of bladder and or bowel mucosa, while 4B includes distant organ metastasis. It also involves metastasis to the inguinal lymph nodes.
Thank you. So it's very important to understand these stages, because when the doctor is going to suggest you radiation based on the stage, usually first of all is surgical or chemotherapy, or depending on the stage, right? So if the doctor is going for surgical and then is going to suggest you radiation, means that the tissue around the tumor or the cancer is affected. That's why radiation needs to be done. Sometimes patients, they just listen to the suggestion of the provider and they don't understand the extension of the tumor, so either they reject or they accept, or they don't ask questions. So it's important to know the stages and the extension of the cancer. Okay, so let's go to risk factors for endometrial cancer: early menarche and or late menopause, as we discussed before, use of estrogen after menopause, use of birth control pills or tamoxifen, and we know that tamoxifen is an estrogen modulator, use of an intrauterine device, and nulliparity means that no pregnancy was detected, history of type 2 diabetes, polycystic ovarian syndrome, breast or ovarian cancer, or endometrial hyperplasia, treatment of the pelvis with radiation therapy, obesity, especially if body mass index at age 18 was high. So these are the risk factors. I give you a table in the supplemental file with characteristics and risk factors for the different types of cancers. Let me see if the table is available. This is the file. Risk factors for gynecologic cancer. So you can see here the different. Remember that the uterine is the same as endometrium. Okay, endometrial cancer. Okay, let's continue. So endometrial cancer is strongly associated with conditions causing prolonged exposure to estrogen without the protective effects of progesterone. Although most cases of endometrial cancer do not involve a genetic predisposition, it is more common in families that have gene mutations for hereditary non-polyposis colon cancer. Okay? Meaning that the colon cancer is not presenting with polyps. Is hereditary non-polyposis colon cancer. The main symptom, and this is good to know, the main symptom of endometrial cancer is abnormal uterine bleeding, especially postmenopausal bleeding, uterine cancer. Ask the patient how many tampons or menstrual pads she uses every day. Some women also have a watery, bloody vaginal discharge or low back, low pelvis, or abdominal pain caused by pressure of the enlarged uterus. Several laboratory tests are used to determine the overall condition of the woman with possible or confirmed endometrial cancer, and that's good to know too. A complete blood count may show anemia due to heavy bleeding. Serum tumor markers to assess the metastasis include the CA-125 cancer antigen, CA-125, that's good to know, and alpha-fetoprotein, both of which may be elevated when ovarian cancer is present. Okay, that's good to know hints. Transvaginal ultrasound and endometrial biopsy are the gold standard diagnosis tests to determine the presence of endometrial thickening and cancer. Other diagnosis tests to determine the patient's overall health status and the presence of metastasis are dilation and curettage, hysteroscopy, chest X-ray, and whole body imaging of chest, abdomen, and pelvis, CT, MRI, PET scan, liver and bone scans to assess for distant metastases. So what is the difference between a CT and a PET scan? A CT scan creates a detailed non-moving image of organs, bones, and tissue, while a PET scan shows how the tissue works on a cellular level. A PET scan highlights the abnormal metabolic activity of cancer cells, while a CT scan shows the location of the tumor cells. A PET scan requires a small amount of radioactive material that is injected, inhaled, or swallowed, while a CT scan does not. The most important, the PET scan, when the radioactive fluid is injected or swallowed, is going to highlight, meaning the cancer cells are going to eat, they're going to absorb that fluid. So especially the parts with cancer is going to be highlighted in the image, okay? The CT scan, no, it's only going to show the location. So that's why PET scan is done in metastasis, right? Because it's going to be able to highlight what zones are metastasized due to the cancer. Intervention. Take action. Surgical removal and cancer stages of the tumor with adjacent lymph nodes are the most important intervention for endometrial cancer. Cancer staging is often done using minimally invasive techniques such as laparoscopic or robotic assisted procedures. Radiation therapy. The oncology may prescribe radiation therapy to be delivered by external beam and or brachytherapy depending on stage and grade. The purpose of brachytherapy is to prevent disease recurrence. Here comes in yellow another that's good to know. This procedure is used for women who have had uterus and cervix removed, brachytherapy. The upper part of the vagina is treated when a cylinder is placed inside it by the radiologist. In high-dose rate brachytherapy, each treatment takes about 10 to 20 minutes while the radioactive implant is in place. Radiation is emitted that can affect other people, so others will not be in the room. During radiation brachytherapy that takes place between 10 and 20 minutes, nobody can be with the patient in the room, and that's good to know. Inform the patient that she's restricted to bed rest, so she's going to be 10 to 20 minutes in a room, no company, no family members in the room, and she's going to be in bed rest. That's good to know during the treatment to prevent dislodge of the radioactive source. At the completion of treatment, the woman may go home the same day. There are no restrictions for the woman to stay away from her family or the public between treatments. And please pay attention to this, because many patients feel anxiety, depression, and feelings of loneliness because most of the family members don't want to be around them after the treatment. The problem is not after the treatment. The problem and the restrictions are during the 10 to 20 minutes that the patient will be receiving the brachytherapy. Okay? Best practice for patient safety and quality: health teaching for the patient having brachytherapy for gynecologic cancer, urethral burning for more than 24 hours, and they need to report this immediately. The heavy vaginal bleeding, of course, with any condition, any GYN condition, blood in urine, fatigue, diarrhea, abdominal pain. Okay? Sometimes the radiation is too strong and is taking areas that it's not supposed to be. That's why there is abdominal pain. External beam radiation therapy may be used to treat any stage of endometrial cancer in combination with surgery, brachytherapy, and chemotherapy. The treatment is given on an ambulatory care basis, usually 5 days after, or 4 to 6 weeks, with each session taking less than 30 minutes. Tissue around the tumor and pelvic wall nodes also is treated. Teach the patient to monitor for signs of skin breakdown, especially in the perineal area, to avoid sunbathing and to avoid washing the markings, outlining the treatment sites. Drug therapy: multi-agent chemotherapy is used as palliative treatment in advanced and recurring disease when it has spread to distant parts of the body, and it is not always effective. So based on the experience, it's an empiric treatment that the doctor will prescribe, because if there is no there is a recurrence and metastasis, there's not too much to do. Complementary and integrative health: current evidence-based information is available at the American Cancer Society. Making a about mind therapies, health, healing touch, herbs, vitamins, nutrition, and biologic therapies. My recommendation is when the patient is having metastasis and recurrence, of course, to look for a second opinion in order to decide the best treatment, because it's going to be empiric, really, and to have different approaches. Surgical management: the most common surgical procedure to address endometrial cancer involves the removal of the uterus, fallopian tubes, and ovaries. That is called total hysterectomy and bilateral salpingo oophorectomy. Remember that salpingo is referring to the fallopian tubes, and oophorectomy is referring to the ovaries. Okay, so the most common procedure for endometrial cancer is total hysterectomy and bilateral salpingo oophorectomy. Care, coordination, and transition management: home care after surgery for endometrial cancer is the same as that after a hysterectomy. Yes, it's the same. Most women are surprised by the fatigue caused by radiation and chemotherapy. help the patient and her family plan daily activities around treatment requirements so that she can effectively pace herself. And that's happening after the surgery when the patient is receiving chemo and radiation. High doses of radiation cause sterility and vaginal shrinkage can occur. Vaginal dilators can be used with water-soluble lubricants for 10 minutes, 3 to 4 times weekly, until sexual activity resumes, generally within 4 weeks. Both radiation and chemotherapy have side effects that change physical appearance and body image. Women may have grief reaction to these changes. The feeling of loss depends on the visibility of the loss and the perception of reality of loss of function. So that's why it's extremely important, as important as having a procedure or deciding the treatment. I would say it's extremely important, even before deciding the procedure, to check the support around the patient. If the patient is having a family that can support her, what is the status of the relationship between family members? If the family has spiritual support, how is the mental status? If the patient is going through anxiety, depression, um, all this is as important as deciding the treatment and the provider that is going to take care of the patient. Death can occur with or without treatment. The goal is for the patient to meet and exceed the 5-year survival mark without a recurrence of disease, and this is with any type of cancer, 5 years survival. If the tumor recurs and cure is not likely, the woman and her family need to consider hospice care and whether she can be cared for in the home. And here we are going to stop the lecture, and then we are going to come back for part 3 of chapter 66.